Good morning, everybody. You're wondering what a cardiologist, interventional cardiologist, is doing in your, I guess, seminar. A reason behind is because I got interested in testosterone. I'll try to give earlier slides are just how I got involved, what question that came, and what we showed before Trevor's trial. Actually, our trials that we have done cause FDA to essentially demand a trial looking at cardiovascular finding. First couple of slides I'll go through very fast, and I'll try to focus because of time limitations on atrial fibrillation. I have, let's see if I'll do it right. Okay, I have no disclosure related to this. Again, cardiovascular effect of testosterone. These are all physiological effect. At physiological level, it affects endothelial function, hemodynamics, cardiovascular inflammation, conduction tissue, which is basically related to atrial fibrillation, a shortened QT interval, and result improve antiarrhythmic substrate essentially. On lipid level, it doesn't have any specific effect. Myocardial protection, it decreased perfusion injury. That means if you had MI and if you get reperfused, that tend to, at physiological level, it tend to reduce that reperfusion injury. Atheroma itself, it's a matter of debate, but in basic science model, there was not much difference. But if you look at the CT follow-up, there are some coronary CT follow-up. There were debate how this testosterone is affecting the remodeling of the atheroma. That debate is still going on. Biggest worry was thrombosis. Most of the basic science data came out of ex vivo. That means the patient got testosterone, they took their blood, then treated platelets with their blood or serum, and found that they're probably more thrombogenic. However, that was the reason. Mainly, the thesis came out that maybe cardiovascular events are affected because of the prothrombogenic research. But again, that was mainly came out of a bench research. I'm a bench researcher myself, in addition to a interventional cardiologist, but that was not, those two studies were not well done, essentially. In general, low testosterone associated with higher mortality. This is the list. I'll not go over through that. The worry about signal of cardiogenic adverse effect came out of TOM trial. Basically, they found that there may be a higher event signal of MI or arrhythmic events. However, this is also not tested for cardiovascular outcome. They were looking at fracture actually. So subsequently, I'm going wrong direction. Then VIGES data. This is the biggest hoopla that created. This is from VA database. Essentially, these patients were coming to the cath lab. And in that cath lab population, high-risk population, they, proposed that testosterone was associated maybe higher events. So there were some other clinical data flows saying the same. Also, again, it's a database extraction. So this got me, essentially got involved in the testosterone trial. So this was the first trial we did. It's all VAs, all comers, and we did really thorough examination and looked at 3 different groups. That means you had truly hypogonadal, 2 separate measurements, and there were 3 groups. Those guys who had truly hypogonadal did not receive any testosterone. Those who received testosterone but not normalized, and those who received and normalized. We found totally opposite. We adjusted for all risk factors here, that in a patients without any previous cardiovascular event, there was improved mortality, improved MI as well as stroke. So that was after that. Then we worried what happens to the patients who had previous MI. This is again this population similar to Traverse trial population, patient who already had a previous MI. We looked at them in a similar fashion. Patient who were not treated, truly hypogonadal, treated, did not normalize, treated but normalized. In that population, we did not see the benefit of mortality, but we did not see the signal of harm that was previously people were proposing. So we found, because once you have an MI, a cardiovascular event, patients has multiple physiological and pathophysiological changes in the body. So testosterone itself that you saw in a non-cardiovascular risk patient, unlikely to show the same benefit. This is essentially proven by Traverse trial. These two data were at least 4 or 5 years before Traverse trial we published. Now atrial fibrillation, and what is atrial fibrillation? Is the most common cardiac arrhythmia worldwide. Men will have 1/5-fold higher risk of developing Afib, and increase of incidence of Afib appears to coincide with the decrease of serum T. It means you start seeing them in age 65, peaks around mostly at 75 years of age. So preclinical and animal studies have shown that T, deficiency of T is associated with increased atrial fibrillation signaling, which can be attenuated by exogenous T. So there are some observational data from Rosenberg. It's about 1,000 men, about average 65 T level was decreased T level was higher risk for developing Afib, and after adjusting for risk factor. Similarly, firming homeostasis, these were 55 to 69 years. With every standard deviation of decrease in T level was associated increase instead of Afib. So looking at this way we looked at MI and cardiovascular event, we also looked at, this is in American Heart Journal 2017 we published, there were patients who were truly hypogonadal, did not receive any testosterone, and received testosterone, did not normalize, and received testosterone and normalization. We found the similar signaling that decreased testosterone associated with higher Afib. Only normalization has decreased the event of atrial fibrillation. This is, again, patients were adjusted for all cardiovascular risk factors. So now is Traverse trial. You are all, I guess, well versed with this, so I'm not going to go over too much. Essentially, they showed that there may be a higher non-fatal arrhythmia and atrial fibrillation. So how do you reconcile my data and Traverse trial data? So the issue is population. My population, we really adjusted for all the risk factors. In Traverse trial, there are patients with higher risk factors. And I'm going to show you next two slides. This will actually merge these two findings. These are two perspective. This is a prospective cohort studies by Zhu et al., UK Biobank. They basically 173,000 men who were followed for 11 years. If you see that curve, where this curve merges, they're merging around in here between 10 to 15 nanomole per liter. And there you see the event rate were the lowest, and event was higher even when it is low. Event is high when it is the testosterone reaches a certain level. Same thing. There's another study just came out. You'll see post analysis of 4,000 people. So the event rate is lowest when you're keeping your testosterone level between 10 and 20 nanomole. That essentially proves what we found, and somewhat merges your Traverse trial data. So Traverse trial, remember, they targeted range was 350 to 750. So some of the Traverse patients will be higher than if you take care of 10 versus 20 nanomole. It falls between 300 to 550 basically range of your testosterone level. So to me, that proves the fact that your therapeutic range for, see, testosterone is a medication. It has its own effect. Then also you have a patient. You have to look at patient's risk factor. Also, you have to look at the range of your testosterone level. So therapeutic range for testosterone benefiting atrial fibrillation may be very narrow. So that sits between, based on those two, all this data I presented falls between 350 to 550 nanogram per DL. Otherwise, if it is lower than that, most likely you will have higher events. And if it is higher than that, you most likely will have higher event. Also, you have to, in clinical practice, you have to see what your patients are like. If the patient has sleep apnea, that is a trigger for atrial fibrillation. If some patient, if you give testosterone, they exacerbate sleep apnea. So those kind of things interact. So you have to identify your patients appropriately and give the appropriate range of therapeutic treatment. So essentially, I'll read the last couple of lines there. Most preclinical and observational data suggest low total T associated increased AFib event. Our largest observational study to date, without prior event of AFib normalization, also low T to TRT was also decreased. The recent Traverse trial associated increased incident, but above trial combined with all the other two trials demonstrate that effect of testosterone is not linear on atrial fibrillation. So it's likely a U-shaped curve with the lowest incident occurring between mid-range values of concentration. Thank you.